Welcome, emergency nursing students, to this explainer. Look, let's just dive right into Microbiology Unit 9 together. Today, we're focusing on the microscopic invaders that you are absolutely going to encounter on the front lines of patient care.
Since we're grounding this directly in your Can UNIS Training Center UNRW curriculum, we're really going to focus on translating these microscopic bugs into real-world emergency triage profiles. You aren't just memorizing biology today, you're learning how to quickly spot and understand the unseen enemies causing your patients severe symptoms.
Here's our clinical syllabus for today. First up, toxoplasma, the hidden threat. Then, entamoeba, the dysentery danger. Third, giardia, our waterborne warning. And finally, fungal foes, looking at tinea and candida. Let's get to it.
All right, Section 1, Toxoplasma, the hidden threat, and specifically, the triage risk for expectant mothers.
So, toxoplasmosis. It's a multi-system disease caused by the protozoan Toxoplasma gondii. When a pregnant patient rolls into triage, this pathogen has to be on your radar. Why? Because while it might just cause minor symptoms in adults, if any at all, an acute maternal infection is a totally different story. It can literally cause spontaneous abortion, preterm labor, stillbirth, or severe congenital malformations. It is a massive deal.
So how do they actually get it? Well, human infection usually happens via hand-to-mouth contact. We're talking about everyday hazards, right? Disposing of cat litter or maybe eating undercooked meat from cattle or sheep that grazed in contaminated fields. So when you're taking a history from an expectant mother, asking about domestic cats or what kind of meat they eat, that's not small talk. It's absolutely crucial diagnostic work. Mothers who already have antibodies before getting pregnant, they're actually safe. But those who don't, they need to be warned immediately.
And here is exactly why that warning is a matter of life and death. 10 to 15%. That's the mortality rate for babies born with congenital toxoplasmosis. 10 to 15%. As an emergency nurse, keeping that stark number burned into your brain really underscores why educating mothers on well-cooked meat and avoiding the cat litter box is so critical.
Now, if that primary infection happens early on, first or second trimester, the damage is just devastating. Inside the fetus, these pathogens essentially act as intracellular macrophage parasites, and they migrate straight to the central nervous system. The major clinical red flags you're looking for here are encephalitis and chorioretinitis, which, just as a refresher, is inflammation of the choroid and the retina. By the time this presents in the ER, the developmental and neurological damage is already severe.
Okay, moving on to Section 2. Entamoeba, the dysentery danger. Let's see how this goes from a simple cyst to a very dangerous ulcer.
Let's track the exact pathway this pathogen takes through a patient's gut. It's kind of like a hostile takeover. Step 1, the patient ingests the cyst directly, maybe from a carrier, bad drinking water, or tainted food. Step 2, that incredibly resilient cyst survives the whole journey right into the small intestine. Step 3, it actually hatches, giving us vegetative forms called trophozoites. And finally, step 4, those trophozoites migrate down and set up camp, forming colonies right there in the large intestine.
But here's where the actual emergency starts. They don't just sit there quietly in the colon. These trophozoites actively invade the intestinal wall, and they cause these highly specific, really dangerous flask-shaped ulcers. And honestly, it gets worse. From those ulcers, the parasites can slip into the portal blood circulation, hitch a ride straight to the liver, and cause a hepatic abscess. They can even make it out to the lungs or the brain. So when you see a patient with amoebic dysentery, just remember, you're dealing with a pathogen that is actively eating away the intestinal wall.
All right, Section 3, Giardia, the waterborne warning, the resilient parasite.
So, two intestinal parasites. How do you quickly tell them apart in triage? Well, with entamoeba, patients present with amoebic dysentery. So you're going to see frequent motions with a ton of mucus, but very little blood. Giardia, though, that's a small intestine infection. That patient is going to complain of cramping, bloating, fatigue, weight loss, and this is the real giveaway, chronic greasy diarrhea because they just aren't absorbing nutrients. Keep that mental cheat sheet handy, it'll save you a ton of time.
Now, what makes Giardia an absolute nightmare for public health is its sheer resilience. It's the most frequently identified intestinal parasite out there, mostly spreading human to human through contaminated water. But get this is wild. Giardia cysts completely survive the standard concentrations of chlorine used in normal water treatment. No way around it, standard tap water can still be a vector. It makes managing waterborne outbreaks an incredibly tough, highly resilient challenge.
Okay, let's pivot from protozoa. Section 4, fungal foes, tinea and candida.
We're going from the skin right down to systemic outbreaks.
Let's start on the surface with cutaneous infections. You need to be able to diagnose these two distinct presentations basically on sight. First, tinea versicolor, caused by Malassezia furfur. This shows up as visible skin discoloration mostly on the chest, abdomen, upper limbs, and back. On the flip side, we have tinea nigra. This one is way more localized, caused by Phaeoanalomyces wernickeyi, and it presents as these blackish-brown patches right on the palm or the sole of the foot. Knowing exactly where to look for these variations is going to speed up your physical assessments big time.
All right, let's talk Candida. You really can't just box candidiasis in as a simple skin infection because it presents in a massive variety of ways. Sure, it can cause intertriginous candidiasis, right in the skin folds, or vulvovaginitis, or classic oral thrush. But it can also go dangerously deep. We're talking pulmonary infections, esophagitis, ocular infections, endocarditis, and even full-blown meningitis. It's all over the map.
And I really want to pause on this direct quote from your materials, because it's absolutely vital for anyone working in triage. Candidemia and disseminated disease are seen commonly in immunocompromised hosts, very commonly seen in patients with AIDS. Candida albicans can cause terrible onychomycosis and esophagitis in these patients. This fungal infection is frankly a lethal opportunistic predator. So if an immunocompromised patient comes in, a little oral thrush or a rash in a skin fold, that isn't just a minor annoyance. That is a glaring red warning sign of a potentially fatal disseminated disease.
Of course, to officially confirm this, you're going to rely on the lab. The protocol here is pretty straightforward. A direct microscopic exam of the clinical specimens is going to show you these strongly gram-positive budding yeast cells. And the good news is, they grow incredibly well on just ordinary bacteriological media. That is the definitive proof you'll be checking for on the patient's lab chart.
So, look at what we've covered today. The hidden, devastating dangers of toxoplasma, the distinct, destructive paths of entamoeba and giardia, and the unpredictable, highly opportunistic threats of tinea and candida. But honestly, all of this information is totally useless if it just stays locked in your textbook. So I want to leave you with this question. As an emergency nurse, how are you going to use this knowledge of transmission and these severe clinical outcomes to immediately educate your patients on food safety and hygiene, right there in the triage room? How do you actually break the cycle of infection before it even starts? Think about that as you gear up for your next shift.